everyone. Welcome to this event, Partners in the Myelofibrosis Journey. I would like to welcome everyone in the room and also our virtual, if I can talk, attendees. I'm Sara Tinsley-Vance. I'm one of the panelists, and I'm joined by Dr. Sandra Curtin, and Dr. Catherine Johnson. And we're really so excited to be here talking to you about myelofibrosis, and we want to thank PeerView for organizing this event and the support of GSK and Insight. If you haven't already, please complete your pre-event survey so we can see how we improve. For the people who are in the room, we ask you to use your personal device to scan the QR codes on the following slides, and we really want your participation, and we're incentivizing you. There's going to be a drawing at the end, and the more times you enter and ask a question or respond to the polls, then you get entered more times, and so you increase your odds of winning some cash. Well, I don't know if it's actually cash, but it's probably an Amazon card or something to the effect that you can use on things you like. And for the virtual learners, please participate also by responding to the polls on your screen. And we really want to know that you're here by posing questions, and that helps unite both of us, the people virtually and the people in the room. And then we will be answering the questions at the end of the presentation. So these are the instructions for the in-person learners. If you can scan this QR code, I'm sure you know how to do this, and you can ask questions that way. I'm sorry, did I go too fast? Everybody got it? So like I said, when you enter, you have the chance to win a $50 gift card, and that is provided by PeerView. Every time you answer a poll, submit a question, then you increase your odds of winning. Everybody good on that? And then we do have these practice aids. You can view the slides and practice aids now and download them after the event, which I find that very helpful when I talk to patients or I have another nurse practitioner or a PA that's new to our group that doesn't know what myelofibrosis is. It's very handy to have slides and practice aids available. Let's see what you think. If you can answer this question on your device, this is the polling question number 1. So please scan to answer. I love it. I see phones up. All of the above, 42% of the responses. Very good. Oops. These are our goals for today. We want to improve your understanding of the symptoms that accompany myelofibrosis. We know it's an inflammatory state with lots of symptoms. We're going to also discuss prognostic factors and the evidence on the role of JAK inhibitor therapy. We would like to equip you with the skills you need to educate your patients with myelofibrosis on these modern treatment options and contribute to your overall management of your myelofibrosis patients and their symptoms, and also provide some guidance on the managing dose of these therapies and how to safely administer them and other treatment delivery considerations. What is myelofibrosis? I have patients ask me this all the time. So after you hear it over and over, you're like, how can I say this in a way that they really understand it? So myelo is bone marrow, and fibrosis is scarring. So literally it's scarring of the bone marrow. The only way you can tell if a person has myelofibrosis is by doing that bone marrow biopsy and aspiration. The reticulin stain comes from the That's how we know if a person has fibrosis of the marrow. On the left there, you'll see a reticulin stain of a normal person or a person who does not have increased reticulin fibers. And on the right, I think you can appreciate that that bone marrow looks scarred up. All those little tree-like fibers in there, that is the myelofibrosis patient. And they do grade it on a scale. They have different scales. In our institution, we use 1 to 3+. So the lower the score, the less fibrosis. 3+ is the highest. And so when they have a lot of fibrosis, their bone marrow does not function normally. This is what you see. You have normochromic, normocytic anemia. What's strange to me when I first started taking care of patients with myelofibrosis is it's a myeloproliferative neoplasm. So the other myeloproliferative neoplasms, they make lots of blood counts, either red blood cells, platelets, or white blood cells. But for myelofibrosis, it can really be all over the place. They can have increased platelets or decreased platelets or increased white blood cell count or decreased white blood cell count. Almost all of them at some point will have anemia and progressive cytopenias. But in the beginning, it can be difficult to tell when you have a patient with myelofibrosis. You have to do that bone marrow biopsy. And they have a leukoerythroblastic blood film. We'll go over that later. And they have teardrop poikilocytosis. That means those red blood cells look like little teardrops, and that's because of the structure. That fibrotic marrow, when the red blood cells come out, they look like teardrops instead of a normal red blood cell. Many of them have an enlarged spleen, and as the fibrosis gets worse, their spleen gets bigger. Many of them have lots of symptoms, and they're at risk for thrombosis or hemorrhage, so bleeding or clotting. And we talked about the fibrosis already. And leukemic transformation rate is 10 to 20% over a 10-year period. These are the classic symptoms that we see with myelofibrosis, but fatigue is universal in almost every single patient, just like other cancer patients. This is how we assess the symptoms. We have wonderful tools for evaluating the symptoms that were incorporated into the clinical trials, and they came up with these instruments by actually having focus groups with patients with MPN. And so you go through there, you total them up, and the higher the score, the worse their symptoms. This is a patient of mine's enlarged spleen that we took out, which we don't really recommend these days, but this was before we knew we shouldn't take them out, I think, which speaks to my age, but this is about a 20-pound spleen that looks like a turkey. So it was giving her a lot of symptoms. It extended way down into her pelvic region, and it made her lose her appetite and caused pain and difficult to sleep. It's in that left upper quadrant. They have early satiety, fatigue, and weight loss. I don't know if you can see it that well, but this is showing the leukoerythroblastosis, where the red blood cells and white blood cells are released into the circulation. And you can see those immature forms, including blasts, but you want to see that those blast percentages staying about the same and not increasing, or you know that your patient's headed for trouble. A hemoglobin of 7.4, and there's some poikilocytosis in there. So these are the agents that we are using now to treat myelofibrosis. Thankfully, we have lots of them: ruxolitinib, fedratinib, pacritinib, and momelotinib. What's unifying in these is they're approved for intermediate and high-risk myelofibrosis. Pacritinib more for when platelets are less than 50,000, and momelotinib for patients with anemia, so preferentially how we think of these being administered or prescribed. There are delays in starting treatment. This came from a study of 941 chart reviews in adult patients, and you can see that some patients, it was about 8.5 months before they ever started treatment. 41% of them started hydroxyurea, which doesn't really do a lot for managing symptoms. And then 66% of them didn't initiate second-line treatment until week 156. And at baseline, about 10% of them were transfusion dependent. These are our cases these are patients that we're going to discuss as we go through here. There's Thomas on the left, he has primary myelofibrosis. His spleen's a little enlarged. Hemoglobin's 11.5. White blood cell count's 34,000. Platelets are a little low, 105. You'll notice he has a JAK2 V617F mutation and an ASXL1 mutation, and we have Charlotte, who has a CalR type 2 mutation and ASXL1 and EZH2, and she has a lot of symptoms, and she's progressed after 2 lines of therapy. We really want to include patients in shared decision-making in myelofibrosis. When do I start treatment? What's the right treatment? So you want to be prepared to answer these questions because when they're scared, they have lots of questions. And the more we're prepared, then we can really help them cope and understand their disease and manage their lives better. So Health Tree Foundation, we heard this prior to starting, the ones that were in the room, they really help empower patients by providing personalized support and education for patients to connect to other patients and a patient registry. And there's the address down below, healthtree.org/myelofibrosis. And they do have a nurse advisory board. And if you're interested in being part of this, you want to connect with Cindy at the Health Tree table. So this is interventions for delivering better care. So let's look at our treatments for high-risk myelofibrosis. This is how we stage. We have primary myelofibrosis. We have all these different staging systems, as we call them. It's not patients will ask you, am I stage 4? Well, we don't think of it that way when you have disease in your bone marrow, because your bone marrow is throughout your body. But instead, we use the MIPS-70 or MIPS-70 plus, the DIPS plus. The DIPS, if you don't have karyotyping, and for post-PV or post-ET, we have MySec-PM. And then you can see what the scores need to be for lower risk and higher risk disease. This is how you would enter the information for Thomas. So if you scan the QR code here, you can download the practice aid for all of these prognostic tools. And you'll see that he's high risk by the MIPS-70 and the MIPS-70 plus. This is showing you the CalR mutation and what it means. And then for intermediate risk, you have the JAK2 V617F and the MIPL, and how those are associated with survival and thrombotic risk. And these are other mutations. You may be asked by a patient, what is a mutation? And I like to say mutations are like you have a recipe. Your DNA is your recipe ingredients. It tells your cells how to make another normal cell, and when you have a mutation, you have an altered ingredient. So that would be a mutation to me. If they cook, they might get it. If they don't cook, you might have to try a different version of a mutation. And what are the goals of treatment and treating myelofibrosis patient? You really want to individualize it to the patient in front of you. This is illustrating from this landmark NPM survey on the right how much the doctor's goals and what they think the patient wants doesn't align with what the patient wants. So you can see the one where they're in agreement is prevention of vascular and thrombotic events. But for all of the other ones, the physician respondents thought that the patients really wanted symptom improvement more than anything. And then the slowing and delayed progression of their condition was what the patients were really wanting out of this. But they were almost equal on a better quality of life. And I think we all would want a better quality of life and not to have your disease get worse. But talking to them is really important. These are the guidelines by the NCCN. It's broken down into whether a person wants a transplant and is eligible, you think, for a hematopoietic cell transplant and not a hematopoietic cell transplant candidate. If they're not, if they are, then you would refer them for an allo transplant. If they are not a candidate and their platelets are less than 50, you can see there on the left that you would proceed with pacritinib as a category 1B or momelotinib, which is category 2B. And the platelets are greater than 50,000 or 50 or greater, you have several choices there. You have ruxolitinib, fedratinib, momelotinib, and pacritinib. And you want to monitor the patient's symptoms throughout, and I think that's really where nurses are wonderful, and nurse practitioners and PAs. We really talk to our patients quite a bit and understand and develop that rapport with them over time and really understand what their symptoms are and monitoring it over time to see how they change once they start on a treatment. Also, is evaluating that spleen response. Those were our endpoints in our trials. So JAK inhibitor should be considered for use in patients who are 2 or more months prior to transplant if they have splenomegaly and or constitutional symptoms, and that's because we know if a person with myelofibrosis proceeds to transplant with a really large spleen, their outcomes are not very good. And then before transplant, the JAK inhibitors can be tapered during conditioning, prior to or during conditioning, before their cells are infused from their donor. These are the efficacy from the COMFORT trials for ruxolitinib. You can see they were looking for a durable improvement in splenomegaly, like I said, and their myelofibrosis symptoms. So they wanted a 35% or greater reduction in spleen volume. And on the total symptom score, we saw how we measure symptoms. They wanted 50% improvement in those total symptom scores. So it was both of those were what they were looking for. With those COMFORT trials, there was a better median overall survival with patients treated with ruxolitinib compared to best available therapy. You do want to monitor your patients carefully, CBC with DIF, every 2 to 4 weeks until it's stabilized. You want to consider that this class of medications increases a patient's incidence or risk for viral infections, especially herpes zoster. You want to check lipid panels and evaluate them for non-melanoma skin cancers on regular intervals. Check for ecchymosis, dizziness, headaches, diarrhea, anemia, thrombocytopenia. And then for fedratinib, the long-term efficacy was based on the Jakarta trials. Again, they were looking for improvement in the spleen size and the symptom responses compared to placebo. There is a boxed warning for Wernicke's encephalopathy. I remember this was in clinical trial, and then it stopped, and then it came back. And that was because of these neurologic changes that we found out was related to thiamine deficiency. So you want to check for thiamine before you start the patient on treatment and then monitor the thiamine periodically during treatment. And I have had patients that were therapeutic starting and then they dropped during. So you want to keep their thiamine at a therapeutic level. And then you still have those GI side effects, diarrhea, nausea, vomiting, anemia, thrombocytopenia, and think of the medications that you need to use to help patients with those, and monitoring is very important. And then for pacritinib, the efficacy came from the PERSIST 1 and 2 trials, again looking at reduction in spleen volume and improvement in MF-related symptoms. You can see it's the CBC with DIF every 2 weeks. Again, diarrhea, thrombocytopenia, nausea, and anemia. Really, the thrombocytopenia needs to be monitored very carefully, and also the diarrhea was a large number of patients experience diarrhea. So you want to educate your patient about what to anticipate and when to call you. These are the starting doses by baseline. Platelet counts is what we use for ruxolitinib. If the platelets are 200 or greater than 200, you start with 20 milligrams twice daily. If they're 100 to 200, you use 15 milligrams twice a day, which would be the recommended starting dose for Thomas based on the prescribing recommendations in the package insert. And for 50 to 100, you would go to 5 milligrams BID. And for fedratinib, it's 400 milligrams once daily with or without food. And for pacritinib, it's 200 milligrams orally twice daily. And you want to interrupt or dose reduce in patients who have a QTc greater than 500 milliseconds. So back to Thomas. You see his spleen is enlarged, his blasts are 3%. He's open to a hematopoietic cell transplant. So I'm going to turn to my colleagues and ask, how would you counsel this patient on the need to address his constitutional symptoms before transplant?
Well, I think the thing that makes myelofibrosis so unique is that the aberrant pathway, the JAK-STAT pathway, not only causes you to produce too many cells in the early phases or in polycythemia vera or essential thrombocythemia, but it also upregulates that inflammation that causes all that scarring and is largely the cause of all those symptoms. And so this is not a curable disease. People with high-risk disease may live at most 2 years. So we hear the 8 to 10, years or 8 to 10% turning into leukemia. By definition, he has, he's moving in that direction. So you just have to really be honest. In transplant years, he's young. 60 is like super young. But not everybody wants that, and they don't understand it, and it's certainly not easy. And then there's a lot of other conversations that go into who's a good candidate, and do they have a donor, and all the other things.
Yeah, I think to add to that, we were talking just before we started about how difficult it can be for patients to perceive their symptoms as well. Myelofibrosis is chronic and progressive, and so people can live with it for some time before they even get the diagnosis. And then once they have the diagnosis, they've been able to tolerate, the spleen doesn't usually grow to be 20 pounds overnight, but over time, you start to eat less, and that just becomes the norm. And the fatigue that patients feel, they say it's more than just being tired, like you need to take a nap. It's like a full body fatigue, but it doesn't happen overnight. So I think for Thomas going into these conversations to also help him reorient to what a pre-MF baseline looks like. And as much as we're able to, I like to incorporate caregivers to support that conversation as well, because also usually when patients are new to us, they try to be a little tougher.
Right.
And they'll say, oh, yeah, I'm fine, I'm not having any problems. And then you look at whoever they brought with them, and they're like, no.
Tell them the truth.
You used to garden, and now you don't, and
right?
you used to
It's
make
the
dinner,
truth
and
spot,
it's been
yeah.
a month. Yeah.
Yeah,
So
tell them you're in bed most of the day,
Yeah,
right?
exactly.
Yeah.
Exactly.
Yeah. And you need a caregiver to have a transplant. So that conversation has to start early, right? And some people don't have them.
Yeah.
So that's always challenging.
And how about coaching them? Do you find patients that you just can't really understand what their symptom experience is? Like, how do you pull it out of them? Do you have tricks for that?
I think the first time we show them the TSS, they're like, everything is 0. So the best way I find to approach it is really to get to know our patients.
Yes.
Again, it's
Totally
chronic
agree.
and progressive. We're going to see these people often and for a long time. So understanding who they are outside of the exam room helps contextualize things and helps us to ask the questions a little bit differently. I'll use the example of dinner because that's one of my favorite questions. I have patients who love to cook, and did you make 3 courses or did you make 2? Did you order in? Who did the dishes? And use that as your frame of reference for what they're able to accomplish.
I love
It helps
it.
make it a little bit more tangible.
Yeah.
I like to think of it as things you do for enjoyment and employment. Like, that's how you spend your day, and can you do those things? So really knowing who they are, like you're saying, is so critical because different people have different priorities and what they feel like they're missing. as a part of the symptom burden.
Yeah, I agree. I had a Air Force, he was in the Air Force, he was a pilot, and of course he wasn't flying anymore, but he was teaching people how to fly with those drones. And so I knew when he couldn't go to the airfield, when he couldn't help teach how to fly, that he wasn't really having a good quality of life anymore because of all the discussions we've had. But yeah. And that's one of the principles of improving goal concordant care is when you start those discussions with patients, you have to develop that rapport. And I think nurses just do an excellent job of getting to know their patients and talking to them and developing that rapport and getting to know them well. So be prepared to coach your questions. We went through all of this pretty much, right? What the impact of their symptoms are on their daily activities. There's an instrument I like to use called the Brief Fatigue Inventory from, I think it's an instrument developed at MD Anderson, but it asks specifically, do you have enough, are you so fatigued that you don't want to have any more social interactions? Like you don't want to talk to people, you don't want to go out, you don't want to meet new people, then you know that person's really having a lot of fatigue. Are you too tired, like you were saying, Catherine, to make breakfast, lunch, dinner? Do you just skip it because you're too tired? And I already touched on that last one. So this is back to our case. So if he had splenomegaly and symptoms, what would you recommend as far as JAK inhibitor therapy pre-transplant? Would you recommend it?
We generally try to get, there are criteria for transplant, and there are tools to gauge frailty and look at comorbidities and whether somebody is really a good candidate. And in these patients who are really significantly symptomatic, you can actually sort of prehab them, if you will. It's a big push now across multiple cancer types. Get them tuned up enough so they are stronger and they can actually do better in a transplant. We know people that are really worn down and their comorbidities become even less well controlled as a result of their symptoms from their myelofibrosis. They don't do well in transplants. So yes, we would start them on a JAK inhibitor while we're getting everything lined up, if this is what they want to do, to try to improve their performance status so they do better with transplant.
Yeah, and then I think, you touched so nicely on the JAK-STAT pathway. The getting control of the inflammation to help him feel better will help improve his performance status. And then the splenomegaly component is such a critical piece of transplant success as well. We don't often recommend that you take the spleen out, but sometimes if people are gearing up for transplant, that's if we don't shrink the spleen, if we don't use the therapies we have to try to do that, then it becomes a very real part of the conversation.
Mm-hmm. What dose of Rux, if you started him on Rux, would you start with platelets of 105? If we follow the package insert, it would be...
The label says we start with 15 twice a day. I think it depends on where I'm seeing Thomas in practice to some degree as well. If he's able to come to get his labs done often, I may even once a week when we first start, then yeah, let's start him at 15. But if we're not able to have the same level of access, if he's going to be a little further out, might want to start a little bit more cautiously, which we can do.
Okay.
Yeah.
So depending on whether you can monitor him closely would change how you dosed him.
Agree.
And how do you avoid underdosing? I think you spoke to that. You start with the highest dose that's recommended and then monitor him closely. And what dose adjustments would you recommend with cytopenias?
Well, it all depends on where you practice and do you have access to transfusion medicine readily, and that's not a given across the country,
Right.
even in large cities. I'm always surprised. We're very spoiled. We can have a patient come, get labs, get blood, platelets all in the same day. That doesn't happen a lot of places, so you have to be realistic on what you're able to support. And then I guess the other thing I would add is what is our, I always call it the end game. Are we trying to get to transplant? We're going to push a little harder to try to control the disease and the symptoms because we know we've got a way to rescue that patient, and we may be a little bit more aggressive,
Right.
at least in our practice,
Right.
as opposed to this is what we're going to do for the foreseeable, as long as you live, is we're going to treat you. And then we tend to be a little less aggressive in some patients because it doesn't help you if you make them so sick and then they don't want to continue. So it's really
Right.
goals of care,
Right. Lots of
individual.
discussion.
Yeah.
And what about if you didn't start with ruxolitinib but fedratinib? How would you counsel him before you started?
Yeah, check the thiamine.
Yeah, check the
correct it.
thiamine.
Check thiamine.
Same process, really.
Yeah.
Yeah.
All right.
I think also
Anything else?
something that we've talked about that fits with this part of the conversation too is that we're not looking to normalize the counts
Yeah,
necessarily.
right. Very good.
And I think, while there's a lot that patients have in common, no patient really is going to look the same to one another. So the goals will be a little bit different. And we may tolerate patients of 50 differently in Thomas than we will in our patient later on. So I think that sort of helps inform how we approach the care plan too.
Okay. And how would you prepare this patient to transition off of JAK inhibitor therapy to allo transplant, assuming he gets a good response?
Yeah, well, that has to be done carefully because you can have a flare of that JAK-STAT pathway, and it can be pretty dramatic. In the early days when we did the original trials for Rux, we lovingly call it Rux, we didn't know this, and people got very, very sick. And so we now taper and transition, unless they're going on a clinical trial, and then that gets a little bit more tricky. We talked about that earlier. But yes, it has to be done very carefully. And then you need to know you have the next thing approved in your hot little hands and ready to go before you start transitioning them off. Because even if the Rux isn't optimally working, it's probably doing something.
And when you educate patients, do you write it out too, or do you give them anything to take home with them, or is it all verbal?
In how to taper?
Tapering and just like in conversations in general. I mean, everybody has a different style.
We try to write things down.
You try to write.
Yeah.
I love teach back too.
Yes.
You're like, yes,
Yeah.
back.
Yep.
Yeah.
Yeah. And I think
That's a good
anticipatory
point.
guidance goes a long way as well. If patients know what to expect and what that withdrawal syndrome can look like, then it's
Right.
a lot more effective in being able to manage it before it gets to be at a point that becomes really tricky.
Yeah, make
Yes.
sure they know what numbers to call in the middle of the
Yes.
night.
Exactly.
Because we always
exactly.
have problems when nobody's around.
And then your elevator speech, right? Like how you articulate that in an emergency room.
Right,
You
right.
practice.
If he had presented with low baseline platelets, could lower doses of Rux or pacritinib have been considered?
Absolutely.
Yeah.
Absolutely. You had the nice slide with the NCCN guidelines. Pacritinib is frontline for patients
Yes.
with platelets under 50, and then we can taper down ruxolitinib to adjust to the platelets, and there's the recommendation to start with 5 twice a day if platelets are under 100. So absolutely.
And then if they had if he starts with low platelets and then the platelets improve, do you go back up on a higher dose to get the maximum response, or do you kind of
I'm
stay
nodding
at the
yes,
same
but-
dose?
Not always. That's where the
True.
end game question comes in. I mean, you
Okay.
want to optimally control the symptoms, and you want to optimally control, reduce splenomegaly. So yes, if those are major issues, but some people have benefit and they aren't going to transplant, and then we may not dose escalate everybody. It's not a given.
That's
At
true.
least in our practice.
I was thinking
Yeah.
highest effective dose, but
Yes.
effective is in the eye of
Yes.
the beholder.
Yes.
Okay, so this is our recap, just summing it all up. Thomas was a patient with high-risk primary myelofibrosis. He did have splenomegaly and constitutional symptoms. His goal was to get to transplant, and he's eligible. He has a good performance status. He doesn't have a lot of comorbidities. But he did have the big spleen and the symptoms, so you want to start him on some treatment before transplant. And For baseline platelets of 105, Rux and fedratinib are category 1. When using ruxolitinib, you might start at a lower dose if it's a useful real-world strategy. That's sometimes what we do if we're not trying to get them to transplant. And then a baseline platelets of 48. Pacritinib is a category 1 recommendations. And lower dose of Rux is also supported by evidence. So with that, I will pass it off to Sandy.
Okay, thank you very much.
Oh, wait.
Oh.
I'm sorry.
No, you're not.
Polling questions. So again, for everybody in the room, please respond to increase your chances of a $50 gift card.
It's like how we bribe our children.
Yes.
You get 3
That's
jelly
true.
beans.
I need to up my
And
budget.
people, and the virtual attendees too, please answer.
For grandchildren in this case, yeah.
Very good. Smart group.
Nice.
Now we're back to his case again. How would you coach him to be more aware of the impact of his symptoms? What do you think? Please scan to answer. Very good. Yeah, I totally agree.
Great.
Okay, now it's
Thank
Sandy's
you.
turn.
All right,
Sorry.
thank you. Nice.
Thanks.
Okay, the next section, we're going to shift gears and talk specifically about myelofibrosis-associated anemia and implications for nursing care. And so I think anemia is a very big part of really all myeloid malignancies, but particularly myelofibrosis. As the bone marrow becomes more fibrotic, it's not, you're not having normal hematopoiesis, including erythropoiesis, or the production of red blood cells. And that can cause a significant component of that symptom burden. So increased fatigue and weakness, so it definitely contributes to that. You can have shortness of breath and dizziness. This is particularly relevant in patients who have underlying cardiopulmonary disease. You ultimately, over time, every patient is going to become transfusion dependent, and transfusion dependence in clinical trials is considered to be 2 units over an a period of 8 weeks, or rolling 8 weeks. That's what they use in the trials anyway to measure that. Some people need more than that, some people need less than that. Worse disease prognosis, I'm going to come back to that. Certainly a strain on the heart. We know that chronic anemia over time is associated with increased death. Cardiovascular disease, there are many studies that have documented that across multiple disease types. Reduced effectiveness of some treatments. And that comes from just a comfort level of, having cytopenias and being comfortable with people with chronic cytopenias, and we may pull back on their therapeutic interventions as a result of that. And then it actually does contribute to lower immune function as well. So we know there are different normal levels for men and women. And then the degree of anemia is defined for either mild, moderate, or severe. We're going to talk about transfusions in a moment, but I think what's really critical, and it'll be interesting to have a conversation later with the group, is how do we decide when somebody needs to have a red blood cell transfusion? This is that survival data, and this is pretty powerful. So taking away all other risk factors, so just patients with myelofibrosis, regardless of their MIPS 70 score or their MySEC, that risk stratification, just by virtue of developing transfusion dependence. This is a little tricky because it says increase RBC transfusion independence and the nor decrease in transfusion dependence. So the difference, and these are median survivals, so you can clearly see that patients who are transfusion independent, not needing transfusions, do much better than patients who require regular transfusions. And, I always say Kaplan-Meier curves, you want to know if the line goes straight down, that's not good. That's what I learned in PhD school. But also the curves separate early and they stay separated over time. And so this is a significant difference in survival just by this one feature. So really important to keep that in mind. So when we look at how do we approach a patient who has myelofibrosis and anemia, we're going to find out, are they symptomatic? Remember, treating the anemia by itself is not going to help the underlying disease of myelofibrosis. So the inflammation, the symptom burden, the splenomegaly. So giving blood is going to do nothing for that. It's temporary, it's borrowed, those cells don't last forever. I know our patients they get very savvy. They say, what's the expiration date for that unit? Because, the shelf life, it's 42 days. And if you get one that's 41 days, it's technically not expired, but they know, like, no, I want the blood from the young basketball player, right? And I want it, and it's on day 3. So they get very savvy. So if they're not symptomatic, we may look at, if they're symptomatic, we're going to try to control that disease. So use a JAK inhibitor. Remember, that's what we need to suppress that inflammation and all of the secondary symptoms. Clinical trials are always an answer. You're going to hear that from Catherine a little bit later. But other recommended regimens include ruxolitinib. We also might consider adding in things that specifically target erythropoiesis, and I'm going to come back to those in just a moment. So luspatercept, erythropoietin-stimulating agents, and danazol are options. You can also consider changing to momelotinib or pacritinib. If they're not controlled and you really need a JAK inhibitor that preferentially is preferred in a patient with anemia, you still are going to consider a clinical trial, but momelotinib would be your first choice, and we'll talk a little bit more about that in a moment also. You can also consider pacritinib or ruxolitinib combination. A lot of the clinical trials that are coming, you'll hear from Catherine, are using combinations. And then supportive care, which is all it is, luspatercept, ESAs, and danazol along with that. Management of MF-associated anemia with no symptoms or splenomegaly, you're going to say, did we miss something? So we are going to go back and say, folate, B12, iron, are they bleeding? That's always telling if, some of these patients have enormous spleens, their liver's enlarged, they get esophageal varices, and they bleed, and they have slow bleeds from those varices. It's always very telling when they've been transfusion dependent and their ferritin is not elevated. Mm-hmm. That can only happen if they are bleeding somewhere. So I always look for that, and patients like, wait a minute, mm-hmm. right? And you get them scoped and you try to look for that. But again, clinical trial, we're going to consider things to help erythropoiesis, but at the end of the day, we're also going to consider things to help their disease. And then you see another a drug mentioned here, lenalidomide plus prednisone, which is an older regimen that we used a lot more of prior to the JAK inhibitors, but it is an option in some cases, and that's a category 2B. So in terms of momelotinib, I think it's important to understand this is a unique mechanism of action. This is a activin type A inhibitor, so ACVR1 or ALK2. That is upregulated with the inflammation and myelofibrosis, and that then decreases hepcidin. Hepcidin is something that is necessary for iron transport. It's stored in your liver, and if you don't have enough of that, you cannot free up that iron that you need for that late phase erythropoiesis. So when those erythrocytes are growing up, at the very end, you need iron to finish that process. And if that's not available, that's not going to work too well. So this is a unique mechanism of action, and why momelotinib is a preferred agent in patients specifically with anemia. And as you see the clinically significant improvements in that anemia, This drug was compared in the clinical trial to danazol, which is something we had at the time that the study was designed to try to help with erythropoiesis. It did show superior improvement in total symptom score, spleen reduction, and transfusion burden compared to danazol in that study. So that's also important to consider when you're looking at your options. It does have some side effects. You can see some dizziness, the GI symptoms that are very common in most all of these oral drugs. You can see some other cytopenias, thrombocytopenia specifically. And then the neurological symptoms are somewhat vague. You can also see some liver enzymes. This is important. This is a real-world study, so that's always good to go out and, in the real world and get people who are being treated. And in this study of 60 MF patients, it increased hemoglobin levels in 84% of patients. In that cohort of transfusion-dependent individuals, the transfusion requirements improved. And that doesn't sound like a lot, but to me, transfusion dependence, you are so tethered, right? And we're very spoiled again. In a lot of places, a patient has to get labs, and then somebody has to look at them, and they have to call you back and say you need blood, and then you have to get typed, and then you have to go get your blood a day or two later. The more blood you get, the more antibodies you get, and you can't always get blood the same day. They got to find units that you can match. So it really becomes a big part of their lives, and they're tethered to the center. So even reducing that transfusion burden is huge. And if you become transfusion independent, it's very freeing for the patients, not to mention all the other adverse secondary effects. So positive outcomes in this real world analysis. So momelotinib, it's a good thing. It's dosed once a day, and it can be taken with or without food, which always makes things easier for patients. I mentioned the liver issues here, so there are guidelines if they do have Child-Pugh class C liver disease or hepatic impairment. There is a dose modification there, so it is important. And I always talk about the butterfly phenomena, where people's livers and spleens basically take up the whole abdomen and can create a great deal of discomfort, but also lead to this hepatic impairment. Luspatercept is also a newer drug. We've learned a lot about this primarily in MDS, myelodysplastic syndromes, and so this was approved in very low to intermediate risk MDS in patients requiring or who may require RBC transfusions. This is a trap ligand, and so it also is working in that late phase erythropoiesis to help that last bit of development. So those erythrocytes are matured, and they shed their nucleus, and they become happy little red blood cells circulating in the peripheral blood. Mm-hmm. That science has now transferred over in looking at, can this be used in other disease states? And so, yes, there are data in myelofibrosis and anemia using luspatercept to induce improvements in anemia burden in Rux-treated and Rux-naive patients. So there were two different groups, and approximately half of these patients had a greater than or equal to 50% reduction in transfusion burden if they were transfusion dependent. Importantly, the dosing is different. These drugs are given every 3 weeks, so 21 days, but you can see the starting dose in MDS is 1 mg per kg, and the starting dose in luspatercept is 1.33 mg per kg, and then you titrate that up based on response to that final dose of 1.7 milligrams per kilogram. As is true of erythropoietin-stimulating agents, you don't want to raise the hemoglobin too quickly because that can be associated with adverse outcomes. So we do look for blood pressure and have to manage that blood pressure effectively during treatment to avoid any adverse outcomes from that. And so this may be something that needs to be co-managed. I have trouble keeping up with it all, just the oncology drugs, much less all the new blood pressure drugs, so I phone a friend. So we're now back to Thomas, and now Thomas has a hemoglobin of 7.4. His other numbers have amazingly stayed the same over all of this time, but we're changing a few numbers just to make key points. He now has comorbidities that preclude transplant. I think that's a message, because if a patient is young, and that's even something to consider, we want to get them there as soon as we can before they get to the point where they're no longer eligible and we can't tune them up enough. So I'll ask you guys now, what is the role of the nurse in successfully supporting patients with MF and anemia? I'll start with you, Sarah.
Well, I think monitoring them closely, and we have a hard time getting patients in for a transfusion, even though we're an academic center, because we don't have the capacity in our transfusion unit. So we place patients, the nurse helps us place patients earlier in the day in the schedule, so we can hopefully get them in for a transfusion if they need it. And the nurses help us with that. The nurses give the transfusions, and we do, instead of having to go back and do a type and cross from another specimen, we just automatically draw what's called a blood bank hold, and then we turn it into a type and cross match once we see what their hemoglobin is.
Yeah.
And the nurses help us with all of that. So.
They run that completely. In our center, it's like keep that blood band current, right? Because then you always got an active band, and it saves an enormous amount of time. What about you and your practice?
Yeah, I mean, I think the care coordination piece that just goes right along with the monitoring, even from, letting social work know that they're going to need a ride to the infusion center. Sometimes patients need to go to an emergency room because that's where they have access to get the transfusion. So how do we help them facilitate that? And then if we can, trying to get a sense of what the pattern looks like so that we can be a little bit more anticipatory with bringing them in so that we don't have them drop too low.
Yeah, that's a good point. So I'm going to ask you guys this. I mean, there are many challenges of RBC transfusions, logistics a big part of them. There certainly are the risks. I don't know about these, blood bank people like taco trolley. Like, what were they, I don't know, ingesting in the lab, formaldehyde something. They come up with all these
one of
crazy
them was
names.
hungry for tacos.
Yeah, taco trolley, I don't know. But, transfusions are not without risk, right? You can have cardiovascular overload, you can have really bad reactive processes in the lungs, alloimmunization, the antibody development, so it's hard to match the blood.
Yeah.
That becomes really logistically difficult in addition to the iron overload. But let's talk about 7.4. What's your practice? What would you do with Thomas?
I think it would depend on his comorbidities.
Yeah.
Especially for people who have cardiac or pulmonary comorbidities. We don't get a hard pushback at Moffitt if you document it in the note. And they do have people monitoring everything we do. Like, are you using blood the way you should be?
Yes.
And you just document why. So I would, if he has cardiac or pulmonary problems and he's extremely tired and he can't do his normal activities, I would probably at least give him 1 unit of blood.
And that would be the other question, 1 or 2?
Well, I do look at the patient if they're not needing regular transfusions. Like, I know they need 2 units every 2 weeks, If I know that's what's going to happen, then I'll just go ahead and give them 2. But if this is like the first time they've needed blood, I'll give them 1 and see what happens.
Okay. What about you, Catherine?
That's a good question. And I was thinking when I very first started and I was trying to figure everything out, my evidence would have told me I can transfuse under 8. I must transfuse under 7. So I think that's good if you're sort of new, just to have some basic parameters to work with. I think it would really depend on what Thomas looked like in the office that day and what I knew his social patterns to be as well. If he's someone who comes in and is like, I can't even walk up the stairs, I'm lethargic, I'm giving him at least a unit, and if I know he can't come back to me, he's usually a once every 3 weeks guy, but he can't come back for 6 weeks, I'll probably give him 2. But I have to sort of measure that against all the other components that...
Right, so really tailoring it to the patients. Several years ago, ASH, there's these choosing wisely campaigns, and they're usually to say don't do things, not do things. So it's usually, so we got into this mode of restricted transfusion, but the data was based on inpatients, mostly post-surgical patients, where we know that people who get transfusions post-operatively don't do well. That's why all these people that have surgery and they come out, they're all anemic, and you're like, what are those surgeons doing? And they don't even get a CBC. I mean, what is up with that, right? So that's where it came from, but it's not really tailored to hematology, right? So we do have to really personalize it. I think that's really the take-home message. We generally always only give one, unless they're really, 6 or below, because those cells are temporary, right? They're borrowed. But again, if they can't come for 3 weeks, you're going to try to tank them up. And then the question is, do they feel better? Are the transfusions actually helping? And then we have to have the hard conversation about maybe we're at a place where we look at some of these other things or something else.
Yes, this starts fights sometimes, I think.
Yeah,
Patients just demanding blood.
Yeah. Is momelotinib appropriate next step, and what dosing and safety management approaches should be prepared for patients starting on treatment? I'll start with you, Catherine, on that
Again,
one.
absolutely.
Yeah.
I think there used to be a school of watch and wait, and that's not the school I'm sitting in. So I'm very pro starting treatment, particularly because we know he's symptomatic and he's been struggling with this anemia. I think I would start with the label recommended dosing, and I think the same sort of pattern of bringing him back for monitoring. Another thing that I want to be extra careful with my momelotinib patients is the paresthesias that they can get, especially if they have a diabetes comorbidity. So those are the top things I'd be mindful of.
Very good. Same for you,
Yes.
Sarah, pretty much?
Yeah,
Okay.
I usually would bring them back and monitor them closely in the beginning. Like I have a patient that we started, and she actually had low platelets too, but she exhausted all other treatments.
Yeah.
And she had splenomegaly. So even though her platelet count is like 30, we had to dose reduce. But as long as she stays 20 to 30, we haven't taken her off drug because she says, this is really helping me.
And she's not bleeding.
And she's not
obviously.
bleeding, no.
Right. So getting comfortable with those, moderate cytopenias is really what we need, and that can be uncomfortable if you're not used to that. We're like, wow, they're 18. This is so great. We get excited, but you have to really look at the trend over time, and are they symptomatic from that? How can the experience of using luspatercept in MDS prepare nurses for its use in MF? You have a long history in MDS, Sarah, so tell me.
Yes, and we
about
were in
that.
the luspatercept clinical trials for
Yes.
both MDS and with MF. I do think it gives you this comfort to know what other patients have been experiencing, monitoring their blood pressure. We have to go through this ritual of you have to be calm even if you came in, it took you forever to park, or
Yes.
valet was backed up to the road.
Yes. Then we ask you, are you safe at home?
Yes, and you have to uncross your legs and imagine yourself at the beach before they take your blood pressure. Because if your blood pressure is too high, you can't get your dose.
Yeah.
And then how often they come back. And also there's guidelines for dose adjustments and being ready to dose adjust at that appropriate interval. I think it really helps to have had experience with it beforehand, before it hit the market
Great.
for MF.
I think this is the last slide. Do you have anything to add to that, Catherine?
Yes, I want to first say that I meant neuropathy, not paresthesia.
Yeah.
And also nice to know that you do guided meditation with your blood pressure monitoring too. I think I would add, I like to keep a little blood pressure tracker in the chart.
Yes.
And then just generally, I think most of the time, because MF is so rare, it can be a really isolating experience. And so patients will often ask, well, have you had other patients? So being able to borrow from the MDS experience and talk a little bit about what it's like to get this medication has been helpful.
Very good. Very good. Okay. So our recap, this is Thomas. He's still hanging in there with us. He has high risk myelofibrosis, splenomegaly, constitutional symptoms. In this scenario, we really focused on anemia. It's really about all of it, but I think it's important to work through each of the cytopenias and different symptom profiles individually to help that understanding. Able to understand the cause of anemia in these patients, multiple reasons why we would choose momelotinib as a preferred JAK inhibitor because of its unique mechanism of action, and really being able to counsel them on the safety profile for that drug. So a follow-up poll. Assume you're caring for a patient with MF, anemia, uncontrolled symptoms, splenomegaly, and an increasing transfusion burden who inquires about next step. How would you counsel this patient? So I'll let you take a look at your options there. Ooh, some heavy metal.
It's iron overload.
Yeah, there we go. Nice choice of song. There we go. Okay, note that JAK inhibitor therapy with momelotinib made a good, very nice. Well done. And I'm going to turn it over to Catherine. Thank you.
Okay, thank you. Okay. I'm going to jump right on in. So we've talked about the therapies that we have and how do we use them. I'm going to shift us over to what do we do when we can no longer use them. And I'm going to call out the author on this first slide because I'm very lucky to work with him. He's a very brilliant hematologist. Dr. Mascarenhas did a study to show some of the challenges of what it's like to take care of patients who have sort of exhausted their JAK inhibitor therapy options. We know that patients who have had to discontinue ruxolitinib tend to have worse overall survival. It's interesting, I've seen more recently a trend in patients being aware of that as well, is that they can sometimes be resistant to coming off of their their ruxolitinib because of this data. It becomes more complicated to care for them because the rising burden of cytopenias. You can have cytopenias on therapy, but once you're in a position where you need to shift away from therapy, the cytopenias can persist and become even more challenging to manage. And then, like we talked about before, there's also the potential for discontinuation syndrome. They can have symptomatic relapse, worsening of the splenomegaly, and then sometimes that cytokine storm that we get very worried about. So similarly to the prognostic scoring systems that we had at the beginning, there is a new prognostic tool that we can use for patients who are starting to shift into a space where we're concerned about the efficacy of their JAK inhibitor therapy, specifically with ruxolitinib. Several years ago, the folks, I guess in 2022, published a model looking at how patients do on ruxolitinib over time. There were sort of three main criteria that I think can be pulled into the clinical experience in a way that's really helpful. The first is, are patients on ruxolitinib having changes to their transfusion burden? The next is splenomegaly. I think one of the interesting things about this model is that it's the only one that really incorporates splenomegaly. It is a subjective assessment with the physical exam, so I think that's important to take into account as well. But if we start to notice that patients are having progression of their splenomegaly while on therapy, that's something important to note. And then the dose. We've talked a lot about how to manipulate the dosing, but also making sure, the goal is to try to stay within the target for therapeutic range. But what happens and how does that change our ability to stay on therapy over time? What they found is that having, worse burden of any of those things can worsen overall survival, but altogether, if you become more transfusion dependent, if you become in a position where your spleen continues to grow, and then if you're not getting optimal dosing, that you're at very high risk and much worse overall survival potential. So again, we have our NCCN guidelines. I think in this case in particular, we're looking at intolerance or lack of or loss of response to a JAK inhibitor therapy. And I think what's nice about where we are with MF care right now is that we do have options for alternative JAK inhibitor therapies. So if a patient has seen one, we can look back to the guidelines to see what the recommendations are for their situation and see if we can look to an alternate. But the bulk of what I'm going to talk about is clinical trials. Clinical trials are a critical component of care for an MF patient. They are sprinkled all throughout the NCCN guidelines because we don't have a lot of treatment options for these patients. And the more complicated their case becomes, the fewer options we tend to have, especially if they start to become in a situation where they're losing response to the therapies that they're already on. One of the, to phrase it that way, it sounds quite bleak, and it is a very challenging space to be in when we're caring for our patients, but I think I'm going to shift perspective and instead focus on the fact that in the last 4 years, that's when we've gotten these JAK inhibitor therapies. The first one, ruxolitinib, was approved in 2011 or 2012, and we've continued to see growth in this area. And that, to me, is why all of the studies that are listed on this slide, all of these agents, are so exciting, because I think the future is going to be very different, which is really a credit to the patients that we have that have been willing to engage in the scientific process and give up so much of their lives to try to advance the medicine here. So on this slide, there are a number of different agents. And the other thing I think is really interesting is that we know that the JAK-STAT pathway is overactivated in myelofibrosis, but there are other pathologic processes at play, and all of these different agents are hitting different components of what we think is going to be more contributory to disease modification. And so here we've got some studies are phase 1, early stage, some are phase 3, some are combination, some are upfront, some are relapse refractory. The landscape is changing. One of the medications I want to focus on, I think, especially as we get prepared to talk about our case, is a newer medication called imetelstat. Just briefly to go into the mechanism of action, imetelstat is what's called a telomerase inhibitor. And telomeres are these little caps that sit at the end of chromosomes that are supposed to get shorter over time and be a part of the natural death process of apoptosis and how our cells, when they're responsible and behaving how we want them to, know it's time to go. Telomerase is a very tricky enzyme that gives the telomeres permission to just keep going. And we know that this is overactive in some oncologic settings. So in the setting of MF, there's the EMBARK trial, which is a phase 2 study looking at imetelstat usage in patients with relapse refractory myelofibrosis. And here we're really looking at biomarker and the degree of fibrosis changes, like Sara talked about in the beginning, that 1 to 3, to see if there's any changes in that way. What's also really unique about imetelstat is that we, similarly to luspatercept, have a learning experience to share with patients who have myelodysplastic syndrome, which is like a sister disease process. Again, the dosing scheme is going to be a bit different. The dose being tested in MF in the phase 3 study is 9.4 milligrams per kilogram, and that's every 3 weeks rather than every 4, so it's a little bit different. But I think here we can also look to the most common AEs, and the very first couple are decreases in the counts, which are things that we would be worried about in MDS and also match our concerns in myelofibrosis. We're going to do close monitoring of all the chemistries, and then fatigue, which we already know is a very challenging symptom to manage in the setting of myelofibrosis. I also think something unique about imetelstat that we haven't really touched on is that it is delivered via IV, which is unique. The therapies we've talked about so far are oral, which can really change the patient experience. And so here, not only do patients need time in the infusion suite to get the actual infusion, but they need time on board so that they can get their pre-meds as well. And then with that, you have to be educated on what the potential for infusion-related reaction can look like. Separately, but also still very exciting, we have imetelstats being explored in the relapse refractory space, but we also have some newer players that I think are right in line with that positive look to the future. The first one on the left, pelabresib, is a medication being explored really in combination with ruxolitinib for sort of as an upfront use. It's what's called a BET inhibitor or a bromodomain inhibitor. And here, the early data that we have from the studies that have been published show that in combination, its use was associated with improvements in spleen volume, total symptom scoring, anemia, and then changes to the bone marrow microenvironment when compared to placebo. Again, these aren't approved, so I think there's more data to come, and I also think it's important that we recognize some of the imperfections and be critical about the scientific process. And one of the things that also is being paid close attention to in the data review is the rates of accelerated and blast phase progression with the add-on therapy. The next one is a medication called selinexor. actually also both of these therapies are, both pelabresib and selinexor are oral therapies as well, so sort of keeping in that usual theme for myelofibrosis. Selinexor is approved for use in multiple myeloma. Not quite as many parallels as we see with sister MDS, but I think also with very interesting data so far in the setting of myelofibrosis, again, being used in combination with ruxolitinib. In this case, can be used upfront or in for patients who've already been on ruxolitinib. And the data does have evidence that says that there's reduced spleen volume and it's achieved spleen response. And in most clinical trials, what we're talking about with spleen response is spleen volume measurement with objective measure through imaging of 35% or more. Here, again, that sort of critical thinking cap, also being mindful that the most frequent grade 3, so those severe treatment emergent adverse effects, include anemia and thrombocytopenia, which again for these patients are particularly challenging to get a hold of. So when we were sort of talking about what we want the takeaways to be, I had this little outburst of ABC, always be clinical trialing, which is not grammatically correct. So I'm going to shift it to always be considering a clinical trial. And I jumped on that because if you're in sales, it's ABC, always be closing. And if you're in nursing, it's ABC, airway, breathing, circulation. So if you leave with nothing from today, I hope you at least walk away with, what did she say? Always be clinical
ABC,
trialing?
yeah.
I don't know about that, but at least you'll think about clinical trials. So I think really what I want to focus on with this is that it's always a good time to talk with patients about trials. The landscape is changing, it's growing. There's been a lot of work and dedication from providers, from our nurses, from the team across the world, and their patients especially, to advance the science for this disease group. And I think any time is a good time to talk about it. We have studies that are looking at doing add-on therapies in the upfront setting. We have studies that are looking at add-on therapy and studies that are specifically designed for those folks who are finding themselves in the very tricky space of being relapsed and refractory. Another thing is to be prompt. Don't delay these conversations. We're constantly analyzing the data of our patients, understanding what's going on with their care, just like we've talked about, figuring out their anemia trends and figuring out, what their schedule for coming into the office is going to look like. We also are going to get a sense of our patients and what their comfort levels are with having these sometimes tricky conversations. I think we need to meet them where they are, but also make sure that they're clear on what the options are. And clinical trial, just like the NCCN guidelines say, is always something to be considered through this disease course. Another thing to be talking about and considering just on our own is the eligibility for clinical trials. If you go to clinicaltrials.gov, all of the studies should have some of the basic criteria listed, and that'll help inform the conversation with patients as well, especially when we're talking about some of our patients who have comorbidities. How do we help them optimize management there so that we're not setting them up in a space where they maybe were eligible and then it's no longer an option? And then really bridging between academic and community care to make sure that all patients have access to clinical trials if that's part of the plan that makes sense for them. Okay, so now we have our new case. Her name is Charlotte. She's a 78-year-old woman with JAK inhibitor refractory myelofibrosis. She's CALR type 2. She's got 2 of our high-risk mutations, the ASXL1 and EZH. She has when she first started, she had significant constitutional symptoms, including debilitating fatigue and splenomegaly, and she did have a performance score of 1. She initially was treated with ruxolitinib and lost response after 2.5 years, and then she was treated with fedratinib and lost response after a year, and she's got grade 3 fibrosis, and she has an increasing spleen, and now she has a performance score of 2. So I'm going to ask my colleagues, assuming that she has questions about this recent progression, how would you counsel her on therapy expectations now that her symptoms are back?
I would offer a clinical trial.
Yes! Nailed it.
Yeah. No, I mean, I think we have conversations along the way, and we are very transparent with our patients. If we feel like things are moving in the wrong direction, it shouldn't be a great big surprise. Sometimes those big surprises come. Yes. They come and it's like, bam, what happened? Or they are blasting off, leukemic phase. But just it's really having that conversation every day so that it's not a big shock and starting to talk about what might be next. trying to maintain performance status so they are eligible for a trial would be my thoughts.
Yes, I agree. I think that building that relationship with your patient and to ask them, is it okay to talk about things are serious now? And do you want other family members here when you start to have those conversations? And we look to see, when we're thinking about clinical trials, we look and see how far away they live. You know, because that can be a limitation as to whether a clinical trial is available for them.
Yeah,
Unfortunately. So we need better bridges to the community to be able to offer trials locally.
Definitely.
But I think just preparing her and seeing which symptoms are worse for her to try to give her some immediate symptom relief, which usually it's fatigue.
Yeah.
If we could figure out fatigue, we would help so many patients.
We really would.
Yes.
Nurses are smart. We need to figure this
Yes.
something out. But the NCCN does have guidelines for supportive care, and fatigue is one of those. And I've started using that to kind of work through their recommendations, you know, like sleep habits, how much they drink, are they dehydrated,
Yeah.
look at their medication list carefully to see how they're taking them. One of the things I did with my father, I prepare his meds, is he was taking some of the ones that make him really sleepy right when he got out of bed. So that was easy.
Or if you take your Lasix at night, you're going to be up all night and then
Yeah.
you're going to be really tired.
Yeah. So even just having a really
Practical.
practical applications and what they find most enjoyable and putting that at the time when they have the most energy.
I think the one thing we've learned about fatigue, since we're talking about it, is really there's no magic.
No.
It's all of the things together, and probably one of the biggest issues is exercise. And it doesn't mean you have to go to the gym and do all the machines. Just doing strength training with the elastic bands, even sitting in a chair and doing that, doing chair yoga.
I think that was one of our questions
yes,
about, do you refer people to
Yeah.
physical therapy or occupational
Yeah, and
therapy?
getting
I
them-
do
Absolutely.
a lot.
So they're safe.
Absolutely.
They feel like they're not going to fall
Yep.
because they're weak. But getting them to just do a little bit each day. I demonstrate in the clinic all the time about how to do the elastic bands,
The little
and
bands,
mini
yeah.
squats, holding on so they don't fall. It really does make a difference in stamina. Being able to do something without getting completely wiped out.
Yeah, I completely agree. We like to say objects in motion stay in motion.
Yes, there you go.
Which is
That's right.
another borrowed phrase, but I think one that really fits here.
And I love pets, so
Yes.
if you think they could take good care of a pet, even
Yes.
just getting up to let a pet
Motivate.
out or taking
Yep.
it for little walks, or if they're not allergic, or those type of things.
Yeah, having something else to focus on too. I think
Yes,
staying-
someone else,
Staying
something
in
else
practice
to
with
focus
social
on.
engagement and staying in practice with activity, I think are critical.
Yeah.
So I think we agree it's time to talk about trials. I guess the question after that is, I'm curious your thoughts. Should we have started the conversation earlier?
Yes, you're supposed to start it really earlier, like goals of care discussions, but also, we do clinical trials here. We have clinical trials that monitor people, their symptoms, even when they're early
Remotely,
stage, to see how bad their symptoms are. Sometimes to see if they qualify for a clinical trial, but also so we can support them better.
I always explain it as a clinical trial is something you can do. This is a treatment you would otherwise not have an option to do. We can always use standard of care,
Yep.
but that clinical trial may not come back up in a way that's available to you while there are slots available and, before the drug comes to market. So I always look at it, never exclude a treatment option, and that means always consider a clinical trial, which is something you can do on a trial that you would not have available otherwise.
Yeah,
so
there's
I
better outcomes
explain
with
it.
trials.
Yes, they get,
So.
yes.
Yeah.
Just from people being watched closely,
yeah.
even
Yep.
if the drug's not working.
Yeah.
Yeah. I agree. We've got more questions, so I'll keep going. I do think also, I think it's an ONS sort of principle that we talk about palliative care at the time of diagnosis, and I think clinical trials fits here too. And I think also sort of unique to the setting of MPNs is that My impression is it's pretty likely that through the course of disease, most patients are at least going to have a clinical trial conversation, if not participate in a clinical trial, just because of the way the landscape is changing. So moving back towards JAK inhibitor therapy, what are some of the most challenging symptoms to address after they've already been through, in this case, 2 lines of treatment? And then we talked about fatigue. Anything
massive
else?
splenomegaly sometimes. Yeah. You know, I had that retired Air Force pilot. His spleen was so large that it came all the way across his body and tucked down into his pelvis, and he was getting all these urinary symptoms, and he had a huge hernia that was causing pain. So it's just like the spleen took over his whole body.
Yeah, can't get comfortable. It's
Yeah.
really, and early satiety is just pushing up into the chest. It really, so just trying to look at what options do we have to try to reduce splenomegaly. I mean, the goals are still similar, and then, or what do they want? Like, what is their goal of care?
I think fatigue and splenomegaly.
Yeah. And then outside of trials, we can look to momelotinib and pacritinib, and I think that's where the comparators and the data you have shown about danazol and the brief mention of hydroxyurea, those don't have the same data on spleen volume. So I think those are important things to incorporate into our conversation. And then what about transitioning? Transitioning from either from one JAK inhibitor to another or to a different kind of treatment. What does that look like in your practice?
Well, I talked about it a little bit, not to, that you're going to bridge them, and we do taper. I know you mentioned in a gap, because they have to be off things for a clinical trial, you would use prednisone. But you really do need to be very specific about not stopping abruptly.
Right.
Because they can become very sick. So we map it out depending on the patient and what our next choice is.
Yes.
Yeah.
And phone calls and steroids are good.
Yep.
Phone calls and steroids, yes. If in doubt, give steroids, yes.
Yeah. I'm running a little low on time, so I'm going to jump to our most recent question was, how can the nurse be helpful in engaging patients in clinical trials? And I think we've touched on that pretty well. As a case recap for Charlotte, she's a patient who has JAK inhibitor refractory myelofibrosis. And so this is a patient who's really not improving despite several lines of therapy. She should definitely be educated on her prognosis, and we want to do a lot of patient engagement to have her feel empowered in the conversation she's having with her providers. It's not time to give up. It's time to either have or revisit the conversation about clinical trials and other therapy options. And then I think the coordination and partnership between nurse, patient, the academic center, all of the different pieces and parties involved with clinical trials. Sarah, you mentioned this briefly, but there are studies that show that patients who participate in trials do tend to have better outcomes because of the amount of oversight involved. There's the clinical team, and then there's also a whole staff of other people involved to help make the process move forward. So now I will shift to our question. In your practice, when will you now talk to patients about clinical trial enrollment? All right.
Nice.
Majority of people at diagnosis.
That's good.
So that's good. Okay, I'm going to shift it over to Sarah after a brief apology. I did promise to be a New Yorker and talk fast. I went a little over. I'm sorry.
No, that's fine. So you can scan the QR code again to ask us questions. Even if you've asked another question, you can put another one in, because it increases your probability of being chosen for the $50.
Do we want to
Gift card.
answer do we have time to answer a couple questions? Yeah? Okay. Oh, it's on the clock. Okay.
Thanks.
From the iPad?
Yeah. Okay. Which one do you want to?
There's one that says, any issues with insurance covering the cost of JAK inhibitors, especially the newer ones, you just have to be sure you document that they meet that criteria, the approved indication. And as long as we do that in our notes, we generally don't have a lot of trouble. I mean, there's exceptions. Certain insurance plans are better than others,
Difficult,
but
yeah.
mostly if it's documented and it meets the criteria, then
As
it's
far as getting the medications
getting
paid
it paid for,
we
yeah.
use the foundation support,
Yeah.
Leukemia and Lymphoma Society, the websites of the Insight and all of the pharmaceutical companies that make these drugs is
Yeah.
another option.
Cost should not be a reason for intolerance. It's a key period to check in with social work.
There's lots and lots of questions.
Yeah. There's one, Catherine, that might be good for you. What do you suggest for long-term follow-up with patients who live in remote rural areas? You're a center of excellence, obviously, and you're in the city. I imagine you have people that come from outlying
do,
areas. So
yeah.
how do you manage that?
We have patients who sometimes will just come check in with us once a year. I think we can utilize telehealth. I think
Yes.
that's really valuable in terms of checking in with symptomatology, especially for spleen complaints. And then I also think, communication between providers, if, depending on how bad the commute is to get into a primary care can help us understand, they can at least get a CBC for us. We can check those counts. I think we want to utilize our oral medications. I think we want to make sure that they have a good understanding of what their emergency precautions are, and then staying in close touch with the patient, their support people, and then especially their care providers to make sure everybody's on the same page.
Yeah, I agree. We use external lab, like an ALRN link, and it'll pull their labs from Quest and LabCorp into our electronic medical records. And then you do that before you have a Zoom visit with them, and you basically can still manage them without actually seeing them. So, yeah, we do that.
Great.
There's one about what infection mitigation strategy should we use before a patient starts on a JAK inhibitor, and do they change based on the agent used?
I think my initial thought on this question is a little different. I don't know that we need prophylactic therapies, but I definitely want to recommend that if you're starting on a JAK inhibitor therapy, you're up to date on your vaccines, especially if you're eligible for your shingles vaccine.
Yes.
So I think
Yes.
that would be a key component of the infection prevention piece. And then, monitoring, I think, will be a little bit different depending on what the counts are coming in.
I do have one patient that has
Go ahead.
herpes in the eye, had a very bad infection, that can make you go blind. So he stays on preventive medications, and he also has very expensive drops that he uses in his eyes, and he has myelofibrosis, so.
And I think it's just important that, we always think about the risk of infection being associated with, bone marrow transplant or B-cell malignancies. These patients that are on these JAK inhibitors, you're suppressing the pathway for hematopoiesis and also some of the cytokine development. And so these patients do become immunocompromised. And if they do have infectious symptoms, we want them to call us, because we're going to react differently to those symptoms than the next care, the Walgreens urgent care, right? So we want them to call us and not necessarily their PCP, just so that we're aware and we can weigh in. The other thing I would say for prevention is we refer every single patient. I'm in Arizona. There's a lot of sun there.
Yes.
Everybody sees a dermatologist.
Yes,
Right.
they leave
They
the
get
first visit with
screened.
a lot of homework.
Yep. And you're going to see a dermatologist when you start a JAK inhibitor.
Now, we did get several questions about patients not really wanting to tell us about their symptoms or their toxicities. And I would say, yes, we do sometimes get those patients who want to be the good patient and not tell you how it really is. I don't know what your experience
Yeah, I
as far
think
as how do
that's
you
true.
draw them out? How do you get them to really tell you?
I think that's where the
experience.
nurses play such a role too. If they're in their 15-minute provider visit, 20-minute provider visit, and they're, it's a different feel. I mean, we try to build that rapport, so we really talk with them and bring the truth squad, the people that are going to tell on them. But I think they have a different comfort level when they go see the nurses, and they'll tell them, and then we get calls to say, "Did you know that blah blah blah?" We're like,
Yes,
"No, my
from the
gosh, I just
transfusion
talked to
unit
him,
nurse.
and he said he was fine." Right?
Yep.
So it's really important to just have that conversation and have them feel like safe to talk, I guess.
Yeah,
Yeah.
absolutely. I think
Yeah.
we do EKGs a lot. I think that's an important part of monitoring, and it's a good time to kill time by trying to get to know you.
There you go.
Who
That's a
are
good
you?
idea.
Tell me about your dog. Tell me about your
Yeah.
grandkids.
Yeah.
There's one question about can you safely use JAK inhibitors after allo transplant? And if so, any particular considerations we should convey to patients in this setting?
Well, there is data in graft versus host disease, as we
Right.
know, because of the inflammatory part of that process. And so there are roles for GVH, and you know, and I guess not really approved indications for maintenance.
Yeah, I think there are also, well, they have the indication for graft versus host disease, and then there's other JAK inhibitors in
Yes.
clinical trials, I know
That
at
is-
Moffitt
right,
for,
so it's not quite
for
there
graft
yet.
versus host
Yes.
disease, but not specifically for
Yeah.
myelofibrosis that I'm aware of. I had a patient who relapsed probably 10 or 12 years post-allo transplant for myelofibrosis, that his disease came back, and he was young enough that we just transplanted him again. That's what we
Yeah.
did.
You can bet they're collecting that data, though,
Oh, yeah.
on all these trials, right? So, answer, be in a clinical trial.
Yes, the clinical trial is a good option.
Yeah.
How can you start a dose of Rux without worrying about underdosing? I think there's a consensus in the community that treats myelofibrosis that Rux 5 milligrams twice a day is not really
Yeah, there's data that shows that it's suboptimal.
a suboptimal dose.
yeah.
But I think monitoring them closely, start with the dose that's recommended, and then, or maybe close to the dose that's recommended, and monitor them carefully.
Yeah, you don't have to start with the high doses necessarily. I mean, you follow what the prescription guidance is. If you notice that things start to shift, then you make an adjustment, but you keep a very close eye and try to get as much of the maximum tolerated dose as you can.
I think we're fortunate because we can bring patients back frequently because we have lots of nurse practitioners and PAs in our clinic, so it's easy for us to see them again. But a nurse in a community setting or even a nurse at Moffitt could do that same thing and monitor blood counts and monitor symptoms.
Yeah.
There was
If a
one
patient
question.
asks-
Oh, sorry.
You want to?
I was going to say there was one question about how do you broker some of the awkward conversations about symptoms patients are symptoms patients are having. I thought that was interesting.
Yeah,
you
what
remember
would you
that one?
do about that, Catherine?
I
What
think-
was the question again?
so that one, I like to try to get ahead of it, and I think when we're starting medication.
Oh, what is your experience with patients who are embarrassed by
Yeah.
toxicities they're experiencing and don't want to admit to them? How do you comfortably talk them?
talk
to
about it
them
first.
Yeah.
I introduce it, especially if it's I'm tired or I'm too nervous to talk about how tired I am. I will tell you, you may feel tired. Just throw it out there in the front. Sometimes if patients are having questions about sexual dysfunction, pregnancy is part of the prescribing information. I just get ahead of it. We talk about it, and then as the wheels turn, as the visits go along, they're like, hey, that time we talked about, can we revisit that? And it helps. Diarrhea, just talk about it up
Yep.
front.
Very good.
You introduce it first.
Okay, very good. Anything else? Okay. So
Ooh, let's see.
now we're going to click to see if you've won.
We need to spin the wheel. We need
Yeah.
we need a
Look
background.
at if you see the green winner. Any winners here? Okay. It has to be a winner. Okay, then
Woohoo!
you'll meet with peer review afterwards. Congratulations. So thank you all for attending. If you visit us at peerreview.com, MF25, and complete and submit your post-test and evaluation for credit. You can also download the slides and practice aids and watch the replay of this event. Thank you so much for attending tonight and being such a wonderful audience.
Thank you.
Enjoy
Have a
Congress.
great rest of the Congress.
Yeah.
Stay hydrated.